Hi, my name is Elizabeth Tatum, and the PICO question I chose was how does constraint-induced movement therapy improve upper extremity function in children with cerebral palsy? The following articles provide evidence to support the use of constraint-induced movement therapy, or CIMT, as an intervention strategy for improving the short-term effectiveness of upper extremity function in children with cerebral palsy. Although the sample size of all four studies was small, they were all randomized controlled trials utilizing follow-up assessments to reevaluate outcomes, demonstrating a good quality of research. The first article that I reviewed studied 30 children between the ages of 4 and 8 diagnosed with congenital hemiparetic cerebral palsy with limited ability to use the affected upper extremity. The intervention group included restraint of the unaffected upper extremity using a sling 6 hours per day for 4 hours in a morning clinic treatment session and for 2 more hours in an afternoon home treatment session, 5 times a week for 4 weeks. A control group participated in the same activities as the intervention group, but the unaffected upper extremity was not restrained. Instead, motivational and cueing techniques were used to encourage use of the affected upper extremity. This group participated in one 4 hour morning clinic session and one 2 hour afternoon home session 5 times per week for 4 hours. Results showed statistical significance between both groups on the quality of upper extremity skills test, with greater improvement in the intervention group, and the isokinetic muscular performance test showing statistically significant changes in only the intervention group, concluding that constraint-induced movement therapy in conjunction with shaping of activities is effective in the improvement of upper extremity function in children with congenital hemiparetic cerebral palsy. The second article studied 51 children, 4.5 to 12 years old, diagnosed with unilateral cerebral palsy having minimal grasping ability of the affected upper extremity. The intervention group combined CIMT and an intensive strengthening program. Constraint of the unaffected upper extremity using a custom splint administered by a parent in the home 1 hour per day, 5 times per week for 10 weeks. They also participated in an intensive therapist supervised strengthening program for 45 minutes, 3 times a week for 10 weeks. The control group also participated in CIMT using a custom splint administered by a parent in the home for 1 hour per day, 5 times a week for 10 weeks. Subjects in this group did not participate in an intensive strengthening program. Results of the assisting hand assessment showed statistically significant scores in the intervention group only, all other outcome measures showing improvements, but no statistical significance between groups. Seeing as both groups participated in CIMT for treatment, this concludes that use of CIMT improves upper extremity function in children diagnosed with cerebral palsy. Articles 3 and 4 will be discussed together because they have the same authors, inclusion criteria, and similar interventions. Article 3 studied 45 children and Article 4 studied 41 children, both between 6 and 12 years old, diagnosed with congenital unilateral spastic cerebral palsy with significant non-use or neglect of the affected upper extremity. The intervention group in both articles restrained the unaffected upper extremity using a mitt wrapped with an elastic bandage, administered in the home by a certified therapist. Subjects in both intervention groups wore the mitt 3.5 to 4 hours per day, 2 times a week for 4 weeks. The control group in Articles 3 and 4 participated in traditional rehabilitation in the home by a certified therapist. Subjects in both groups engaged in traditional rehabilitation for 3.5 to 4 hours, 2 times a week for 4 weeks. All outcome measures in Article 3 showed statistically significant scores between groups, showing greater improvement in the intervention group, concluding that home-based constraint-induced movement therapy generated more functional improvements of the affected upper extremity when compared to traditional rehabilitation. All outcome measures of Article 4 showed statistically significant results between groups with greater improvements in the intervention group, concluding that CIMT performed by a therapist in the home setting promotes better performance in grasping, daily function, and reaching control in children diagnosed with unilateral cerebral palsy when compared to results of the traditional rehabilitation group. An integral aspect of occupational therapy is the use of evidence-based practice. It is very important to have studies and supporting evidence for the treatments and interventions that we use with our clients. Occupational therapists should be aware of constraint-induced movement therapy and the improvements that can be seen when this intervention is used properly. Although constraint-induced movement therapy can have positive impacts when used alone, this treatment can help to significantly improve function when paired with other therapeutic programs. The next step researchers must take regarding constraint-induced movement therapy is to begin investigating its long-term effects. Obtaining this evidence will help to strengthen the use of this treatment in a clinical setting.